We are thrilled to be joined today by Susie and Nasr, who joined the Global Fund a year ago as a disease advisor for malaria. Susie is a public health specialist and clinician with 10 years of field experience in medicine and public health. She worked as a malaria advisor for the U.S. President's Malaria Initiative and for the CDC in both Uganda and Angola. Before that, she worked with Médecins Sans Frontières, or Doctors Without Borders, in a number of countries in Africa and Asia. Today, Susie will be sharing with us some of the significant work the Global Fund has done in support of Sierra Leone and Liberia around the 2014 Ebola crisis. This work, in partnership with the Ministries of Health and the national malaria programs in those countries, WHO, and other international partners, has underscored the power of partnerships in responding to global health challenges. The case study she'll be talking about also demonstrates the important role the Global Fund is playing in health system building and strengthening through its flexibility in programming and the creation of an emergency fund and development of policies in challenging operating environments. So with that, I'll turn the phone over to Susie and let her go through the presentation. Thank you.
Hi, everyone, and thank you all for calling in today. I will just first start with an outline of what I'll talk through in this presentation. As Deb said, I'll be talking specifically about Liberia and Sierra Leone, and we'll start off with some background, talking about the health systems in both countries, malaria past and present, and Ebola past and present. Then I'll go into the overlap between malaria and Ebola, the response of the Global Fund, and the current situation and the way forward. If you go to the next slide, I'll just give some quick background statistics on the two countries. Liberia and Sierra Leone both came out of long civil wars in the early part of the century, where their health systems were completely destroyed and they had to start rebuilding again, rebuilding infrastructure, improving human resources, and all that goes along with restarting a nation. If you look at the statistics in the middle, you have in the blue boxes it has the Africa average and the global average in parentheses, and then on each slide you can see the country statistics. And you can see that in neither country are the statistics acceptable, but it's important to note that these statistics have improved significantly over the past decade since there was peace in both countries. That does not mean that the health systems are strong. They were quite weak before Ebola started, but they were slowly rebuilding. If you go to the next slide, I'll give some background on malaria. Malaria in both of these countries is a significant problem. In this map, you can see the darker the color, the more malaria. While there's been significant progress in the global fight against malaria, and hopefully you've heard the positive news even recently with a press release from UNICEF and WHO on the steady decline in cases and deaths of malaria globally, and we're meeting our MDG target most definitively. Malaria continues to be an important and devastating infectious disease across the world. Approximately 40% of the world's population is at risk of malaria, and there's between 100 and 300 million cases each year worldwide, and an estimated 600,000 deaths. If you look specifically at Liberia and Sierra Leone, you can see that in this map it shows that there are over 100 confirmed cases of malaria per 1,000 population. So that's more than 1 in 10. Go to the next slide. I'm emphasizing the previous points. Here it shows on the left, the bar graph shows the countries that account for the most malaria cases in sub-Saharan Africa. And both Sierra Leone and Liberia make the top 10 of this list. And this is amongst children aged 2 to 10 years old. Malaria in Africa is mostly caused by Plasmodium falciparum, which is the species of parasite, which is the one that can kill. On the right side of the graph, I wanted to show some good news. If you look at the dark blue line, that is West Africa, and that is the decrease in cases amongst the same age population over time. And if you look at the lighter blue line underneath it, that is Africa as a whole. So you can see that significant progress has been made. Going to the next slide, specifically for Liberia and Sierra Leone, you can see that after the civil wars ended in the beginning of the century, you'll see in both cases, you'll see increased reported cases of malaria. Does that mean that malaria got worse? No. What it probably means is that as there was increased access to health care, so rebuilding of health facilities, opening of existing health facilities, improving reporting, populations being able to seek care and doing so, you get increased numbers. And that's likely what you see here. If you look towards the end of the graph, you see a downward turn in both of the countries. And that likely does signify improved malaria prevention and treatment. And that's due to efforts for increasing access to long-lasting insecticide-treated mosquito nets, indoor residual spraying, parasite diagnosis, and treatment. Moving on to Ebola, and I hope you can read some of the small writing on this slide. This gives a short history of Ebola. The first outbreak was in Zaire, which is now Democratic Republic of Congo, in 1976, with 318 cases and 280 deaths. And after that, we are used to hearing of Ebola associated with DRC and Uganda. But until now, Liberia and Sierra Leone had never had outbreaks. Prior to last year's outbreak, the maximum number of cases was 425 in Uganda in 2000 2001. But as of July of this year, the outbreak in West Africa totaled approximately 27,000 cases with 11,000 deaths. Previous outbreaks were also mostly in rural settings. However, in the West African outbreak, it was both in rural and urban areas, and of course we know that Ebola did not stay within the three countries' borders, and showed the possibility of global epidemics with isolated cases and smaller outbreaks across many nations. If you go to the next slide, why am I discussing malaria and Ebola at the same time? While they're completely different infections caused by completely different beasts, Ebola is thought to be transmitted by bats, and then amongst people is transmitted by contact with body fluids. Malaria, on the other hand, is transmitted by mosquitoes. Their presentation is quite similar. As you can see, both start with fever as the most prominent sign. Patients also have headaches, joints, muscle pains, fatigue. Both are diagnosed through taking blood samples. So health workers, every time they're testing for malaria, they're exposing themselves to a very, very small risk, but a risk nonetheless, of exposure to blood-borne pathogens. So normally we think of HIV and hepatitis B, treatable diseases. When there's a risk with Ebola, a disease that has no treatment, health workers weigh the benefit of testing against the risk of exposure. Okay, going to the next slide. So what about prevention and treatment? Are there any similarities there? As I said before, in Ebola, you avoid contact with body fluids of infected persons. So health workers need to wear personal protective equipment, and many of you probably saw images on TV of these full body suits, monkey suits, as some people call them, that do not leave one single part of your body exposed. So that's one method, the main method of protection. Treatment is supportive. So you give fluids, you give food, you control the fever, and you're basically waiting the infection out. Malaria, on the other hand, you can be a lot more active. Primary prevention, you try to interrupt the transmission of malaria. So you try to prevent people and infected mosquito contact. And as I mentioned previously, you do that through long-lasting insecticide-treated nets or indoor residual spraying. And you also want to improve access to diagnosis and treatment. And countries have been working extremely hard in the recent decade to get all suspected malaria cases tested with a parasite-based diagnosis. So either a blood slide or a rapid diagnostic test. And malaria has a cure, and using treatment with artemisinin-based combination therapy. So there are significant differences between the two diseases in how you prevent and treat them. If you go to the next slide. Okay, back to the Ebola outbreak. Maybe you guys have seen these maps or some of these graphs. Ebola exploded in West Africa in the middle of last year. The red line is the case trajectory for Liberia, and the green line, is for Sierra Leone. The map on the right is a heat map. The darker the color, the more the cases. So next slide. So what are the consequences in this situation with a large Ebola epidemic? It's important to remember that historically in sub-Saharan Africa and many other parts of the world, every fever was assumed to be malaria prior to Ebola. But now in these countries, every fever was assumed to be Ebola, and malaria was pushed on the side, although likely made up more of the components of fever in both respective countries. Health posts were being shut down or abandoned. People didn't want to go seek care or were afraid that if they did seek care and had a fever, they would be suspected of having Ebola, or maybe they did actually have Ebola. Health workers, as I'm sure you heard on the news, were overwhelmed. They were getting infected with Ebola, getting sick, dying, and like I mentioned before, abandoning their posts. The government was completely overwhelmed, understaffed, and under-resourced. Malaria was still undoubtedly going undiagnosed and untreated, and definitely, as demonstrated by the statistics I showed earlier, still a much bigger problem in both countries than Ebola. If you remember from the previous slides, Liberia and Sierra Leone average about 1.5 million cases of malaria a year, while for Ebola, the cases were between 10 and 12,000. But both diseases are deadly. Okay, next slide. So we all thought to ourselves, what now, and what can we do as the Global Fund to help? We were of course all concerned about controlling Ebola, but we were also, especially amongst the malaria partners, worrying about the impact Ebola was having on malaria, and vice versa, the impact that malaria was having on Ebola. How frequently was malaria being mistaken for Ebola? Could patients even access services? Should health workers, both at community and facility level, be testing for malaria? Are there now enough bed nets out there to protect the people? Are there enough drugs? And are our tools for malaria sufficient in the current context? During all of this, WHO issued some guidelines recommending suspending diagnosis at community level and suspending diagnosis at health facility level for malaria if the proper personal protective equipment wasn't available. So in that context, the Global Fund and partners got some guidance on how to move forward. As you know, though, Global Fund is an organization focused on HIV, TB, and malaria. We're unable to provide support like emergency humanitarian organizations, as our core mandate is different. We recognize the impact that crises like Ebola can have on the overall health system and on populations that will continue to be affected by the diseases that we do work on, and these diseases, of course, will still remain present. As the symptoms of malaria and Ebola are so similar, and malaria is was still remaining the most likely cause of fever, continuing and even accelerating the fight against malaria was critical to ensure that the overlap, confusion, opportunity for misdiagnosis, etc., whatever you want to call it, between malaria and Ebola was minimized. Not only would these efforts be beneficial for those patients with malaria, but they would have secondary advantages of unburdening the overwhelmed health system to care for Ebola, and, of course, not mix Ebola and malaria patients that were both presenting with fever. Okay. If you go to the next slide. So, what was our immediate response? We did the fast and easy things first. As I mentioned previously, WHO came out with some guidelines to help countries decide what to do for malaria testing. So we disseminated those guidelines to all national malaria control programs and implementing partners. We verified the stocks of antimalarials to ensure that there were sufficient supplies available to treat fever all fever as malaria once we stopped confirmatory diagnosis. We also checked the status of the mass mosquito net campaigns in each country. Both Guinea and Sierra Leone had fortunately just finished campaigns at a national level, but Liberia was in the midst of planning one when Ebola hit. We also provided personal protective equipment and supported training on its use, as well as supported training on case management for malaria. And of course, we coordinated with all the partners on the ground and with the ministries of health to make sure that our investments maximized impact and avoided duplication. If you go to the next slide, I'll talk about Liberia specifically. So as I mentioned, should we be moving forward with a national level BedNet campaign in the context of Ebola? The National Malaria Control Program was stretched because, of course, they were also supporting the Ebola efforts, but trying to focus on planning the campaign at the same time. We thought, should they continue, or was it too risky? Or would the benefits of the campaign protecting people against malaria outweigh the risks? Net distribution campaigns traditionally require door-to-door registration, almost like a census, and then you have central distribution points at either village or a district level where people come and receive nets. Obviously, having central distribution points in the Ebola context is quite risky, and having campaign workers going door to door and at distribution points with multiple contact points was also risky. But it was the high transmission season of malaria was fast approaching in Liberia, and people weren't protected. And they also didn't have access to curative services. So again, with multiple partners and with WHO guidance, the National Malaria Control Program decided to go ahead with the campaign, but they changed the methodology. So instead of going door to door and trying to figure out exactly how many nets each household needed based on the population of the household, they decided to provide 3 nets per household, regardless of household size. And that was based on the average household size of 5 people and wanting to give 1 net per 2 people, so you would round up to 3 nets per household. This got rid of the need for registration as well as mass distribution points, as community health workers would just go door to door, give the 3 nets, and that was it. Global Fund had already planned to support the campaign prior to the epidemic, and we reprogrammed funds to support the change in methodology, and we also procured the extra bed nets needed to cover the gap that resulted in the change of this methodology. As I mentioned, this was a huge collaborative effort. We provided the nets and funding support for a lot of the implementation, and many of the partners shown on the slide, provided technical assistance, logistics, communications, training, additional commodities, and as well as follow-up. If you go to the next slide, in Sierra Leone, they were in a bit of a different situation. As I mentioned earlier, they had already completed a national mosquito net campaign. They suspended lab diagnosis. They suspended community care activities. They had sufficient supplies of malaria treatment, but Ebola cases were still skyrocketing. If you remember the slide before of the trajectory of the Ebola cases in Sierra Leone, at the time, at the end of last year, Sierra Leone was number one in terms of the caseload for Ebola. So we discussed again with partners what would be a good way to try and really hit malaria hard, to try and, one, prevent and control malaria, of course, but also minimize the malaria cases that would be suspected as Ebola. MSF was already trying out something called mass drug administration in Monrovia in Liberia. Mass drug administration means that you're providing a drug to a targeted population on a large scale, covering whole communities. This has been done for many different diseases. For example, lymphatic filariasis, more commonly known as elephantiasis, deworming campaigns for children, and river blindness. It's also been tried for malaria before, especially in the context of malaria elimination, with the idea being that you try to get rid of the malaria parasite in everyone that may have it, whether they're sick with malaria or not. It's a massive intervention, as the name implies, and the aim is for everyone in the targeted area to take antimalarial drugs essentially at the same time, and in this case, to repeat it at least one or more times on monthly intervals. The general idea, as I mentioned before, was that it would reduce the malaria patients, thus relieving the overwhelmed health system so that they could focus on Ebola, as well as reducing the suspected Ebola cases that were really, in fact, malaria. Next slide. How did we do this? The Global Fund is not known as being a fast and flexible partner. But at the beginning of last year, the Global Fund created an emergency fund, a $30 million fund over the period of 2014 to 2016, with the idea to create some flexibility to deal with emergency situations, like an Ebola epidemic. This is increased access. This provides increased access to new funds, so it's on top of the money that they already have the countries have in their existing grants. And the idea is fast, quick service, so that service interruption is not it does not occur. This can be done through existing partners and existing grants, but where those partners are not able to act, there are pre-qualified implementers, for example, UNICEF and Save the Children, that money can be channeled to do some of these interventions. So far to date, it's been used 5 times, and you can see the examples on the slide. The 2 activities that have been supported for malaria have both been in the context of Ebola. So Sierra Leone with $1.6 million and Liberia for $1.6 million as well. Okay, so to the next slide, we can discuss the results. So what happened? In Liberia, the campaign was launched in April of this year. 2.8 million nets were distributed, with an estimated operational coverage of over 100%. What operational coverage means is that given the number of nets that you distributed and the population that you targeted to cover, what would be the coverage that you would expect. And why is it over 100%? As I discussed earlier, as the methodology changed and it wasn't based on population figures per household, but just a straight number of 3 nests per household, you can sometimes overestimate the population you can overestimate the number of nests that may be needed per household. As the campaign just finished in June, we don't yet have the results of the impact on malaria or Ebola, if that were able to be measured. But a survey is likely to be conducted next year. In Sierra Leone, 2 rounds of MDA, so mass drug administration, were conducted, one in December 2014 and the next one in January 2015. 95% of the targeted households were reached, which is quite amazing given the context at the time. And even more amazing is the compliance was 75% and 71% for rounds 1 and 2 respectively. This means that community health workers went house to house giving the first dose of a 3-day treatment course to all individuals in the household, and over 70% of the population took all 3 doses, even if they didn't feel sick. The results of these activities are extremely difficult to measure in a place where the health system is no longer functioning, case reporting is not happening, diagnosis of malaria is no longer occurring. You can just imagine how exactly can you measure the impact of such a thing. We agreed to accept, all of us, that we wouldn't be able to determine the impact with scientific rigor, but the Sierra Leone National Malaria Control Program and the NMCP were able to conduct a rapid impact assessment, which did show that malaria decreased significantly in the targeted areas, and Ebola alerts also decreased significantly after the second round of MDA. So if you go to the next slide, so what is happening now in both countries and what's the way forward? The last situation report from WHO, which was from the last week of September, reported that there were 4 cases in Guinea, but no cases in Sierra Leone since mid-September, and Liberia has been declared Ebola-free as of September 3rd of this year. The countries are working on getting back on their feet, and partners around the world are supporting them in this effort, including us at the Global Fund. We're working with them to use the funds they currently have from us to restart their programs, and we're also making the process easier for them to access the funds from the most recent allocation process. And of course, we're collaborating with all partners to try and coordinate the support for strengthening their systems for health in both countries. Meanwhile, at the Global Fund itself, we're also working on our next strategy, and this experience plays a significant role in the development of the strategy, contributing to discussions on the future of the emergency funds, as well as the development of policies around challenging operating environments, and discussing how best to support health systems while maintaining our disease-specific focus. The fight against Ebola is not yet won, and unfortunately we're likely to see outbreaks in the future. For malaria, the battle is far from over, but through continued commitment, focus, resources, and partnership, we'll all continue the fight. I'd like to also thank and acknowledge several actors. If you go to the next slide, there are a list of partners that contributed to all the efforts that led to this talk, and specifically the Ministries of Health of Liberia and Sierra Leone, which have done an incredible effort in really the most dire of circumstances. And thank you all for listening. And if you have any questions, I think Deb will help me.
Thank you so much, Susie. That was a really illuminating presentation. We have a few questions that have come up, so I'll just take them in order. The first one was, how were measures targeted at children who are so vulnerable to malaria? Were there any different measures taken with regards to that population?
The best thing to address children is to make sure that their communities are protected. So we in malaria, we talk about universal coverage, universal access, universal everything. And by universal, we mean community level and national level coverage for things like mosquito nets and other preventive measures, as well as universal access to diagnosis and treatment. So the best thing that you can do for children is to prevent malaria in the rest of their family and in their communities. For malaria in general, Ebola context aside, we have a lot of efforts focused on children, especially children under 5, who are one of the most vulnerable populations for malaria, because they haven't built up their immunity and can get severe malaria and die. And we target them through integrated community case management, which is community level diagnosis of malaria, and if the diagnosis is found not to be malaria, supporting efforts for pneumonia and diarrheal treatment, which are usually the top 3 causes of fever in children. We also support, in universal coverage campaigns with mosquito nets, we target a channel through the immunization program. And that is not only to make sure that young children get NS, but also is another channel to try and maintain the community level protection that can wane after you have a national level campaign. Great.
And second question, what, in your opinion, are the most important lessons that have been learned if another outbreak or similar emergency occurs in the future?
Looking at the resources on the ground and trying to help countries prioritize what can be done as fast as possible and what is indispensable for operating the health system, as well as maintaining coverage for other diseases that may complicate any kind of epidemic. So one of the reasons that this malaria and Ebola is so critical is if you have 2 diseases presenting with exactly the same symptoms, and it's extremely difficult to tell what is what, maintaining as much as possible malaria services to make sure that you can also dedicate resources directly towards Ebola. If you think about health systems in general, building a functional health system that can deal with something like Ebola on the scale that we've seen, I think that is a long way in coming, especially in these countries that are just recovering from civil war. But looking at how best to target the key components of the health system and work with the countries to strengthen those key components so that they're able to deal with these kinds of situations when they come. I must say there's a million lessons learned, and it's hard to really pick out which ones are the top.
Okay, and moving forward, you mentioned a little bit about how there might be evaluations of the campaigns coming up. But how will this continue to be evaluated, and what are the most significant indicators in those evaluations?
I assume that this is independent of Ebola. But if that's not correct, if the person who asked that question, if they can indicate that. We, in the malaria world, we usually measure the success of a campaign, of course, based on country reports and how everything went in terms of operations and logistics. But what we really want to know and what we would expect to have is a high level of coverage and and a high level of usage, and that will mean that we'll have a successful impact on malaria. So that is usually measured through something called the Malaria Indicator Survey, which is a community-based survey that goes into a select number of households, looks at how many mosquito nets are in the household, where they got the mosquito nets from, who's using them, how they're being used, if they're not being used, why they're not being used, etc. At the same time, in these surveys, there's a blood sample taken from children under 5, and the children under 5 is because they're the most vulnerable for malaria and often have the highest prevalence. And we measure the parasite prevalence in those blood samples, so we can see over time, if you do these surveys serially, what the change is in parasite prevalence amongst children under 5, and track whether your measures are having an impact. But the mosquito nets are not the only thing contributing to any decreases that can be seen in parasite prevalence, and has to be associated with good diagnosis and treatment as well.
Great.
See if I can.
No, go ahead.
In terms of the Mass Drug Administration, just to complete the picture, I don't think that we will measure more of the impact of the Mass Drug Administration on malaria and Ebola. The effect on malaria is transient, because you're giving a treatment dose at one particular point in time, but you're not preventing them from getting malaria the next month or the month after. So what you'll often see in these efforts is a dip in malaria cases, but you will expect that the cases will go back up again. So it's not a permanent fix.
Okay, and I'm going to take my prerogative here and ask a question that I was interested in as Ebola was evolving, and that was what was the role of the CCM, if any, in your work in these countries, and in particular, did the coordination with the actors and people who have been dealing with stigma on the country coordinating mechanisms, did that have any positive sort of cultural impact in fomenting trust or helping with dealing with Ebola?
The CCMs in the case of Liberia, as the campaign was already in activity on the books, I would say, it was easier for them to be involved and be up to speed on the change in methodology. So the National Malaria Control Program and Plan International, which is one of the principal recipients in Liberia, came up with the methodology with support of multiple partners and presented it to the CCM, which endorsed it and sent it along. In Sierra Leone, the CCM was also involved, but not as in depth as it was for Liberia.
Why did this global fund choose to invest in treatment instead of diagnostic testing, which might have ruled out Ebola and helped to strengthen health systems?
Again, a great question. As our mandate is on the 3 diseases, HIV, TB, and malaria, we're not best placed to facilitate diagnostic testing for Ebola. There were other actors working on that aspect. And in terms of diagnosing malaria, the malaria community and the technical advisors at WHO felt it was too risky to ask health workers, and especially community health workers, to do the test for malaria. And rather, it was better to just give treatment for malaria rather than give the diagnostic test first. So that was the rationale. So Global Fund, we work. We're not a technical organization, and we follow the guidance of the technical partners. So if WHO recommended to suspend treatment, we worked with the national counterparts to implement that guidance.
How might the Global Fund support countries in health system strengthening, in the countries, and how might they be doing it differently than in the past? I mean, this gets into questions that are still being sorted out in the strategy process, of course, but where do you think the Global Fund is headed?
Thus far, our primary focus on health systems has been building human resource capacity, supply chain management, and data systems, and to some extent, finance. And I think that we will continue to support those main pillars. What we will do in the future, as Deb has already said, remains to be seen. We need to strike a good balance between maintaining the support for the three diseases, which still need considerable amounts of funding support as well as programmatic support, and striking that balance between that and supporting the health systems, which of course are crucial to the success of the fight against the diseases that we fund. So I would say watch this space. As Deb said, we're embarking on the development of our new strategy, and the discussions on health systems are a big component.
But more generally, I'd say, how does the Global Fund see the role of civil society in plans to support health system strengthening?
The civil society plays a huge role in Sierra Leone and in every other country. And Global Fund relatively recently created a whole department on community rights and gender, which you may be aware of, that is focused, one of its main focuses is working on strengthening the civil society component and their contribution to improving health systems, improving accountability, delivering prevention messages, delivering prevention services, etc. So the civil society we see as a critical and significant partner in our work now and moving forward.
Great, thank you. So again, I really like to thank Dr. Susie Nasr for joining us. As noted at the beginning of our presentation, she is a disease advisor for malaria at the Global Fund. And thank everybody on the phone for participating. Susie, this has been a really terrific and very informative presentation. Thank you again.
Thank you, too.